backup guy, I asked him to confirm if he's going to make it. I didn't get back to me. So I don't know if he's going to be here today or if he's going to wait.
For the presentation?
Yeah. He just said I may not make it, but then I emailed him and said, can you confirm yes or no? And he didn't respond.
Really, for the presentation, they don't need to be there. He needs to see that the exam is an exam.
Yeah, that's basically what grad school kind of says.
Yeah, that's cool.
What's that?
Yeah, right. You're supposed to let that up.
Do I have to?
No.
Oh, good. I got the Borstats looking out for me at least.
Yeah, they're used to Minnesota.
Microphone. Put it on the tie. Tie. Can you hear me? Up here? Hold it right there. Is that sufficient? It's good. Everyone can hear me right now?
Hey, you gotta remember, you gotta be up here.
Yeah, I know. I gotta stand by the podium. Jimmy says no wandering around the room.
That mic is multi-directional.
Multi-directional?
So there's a little knob on the back that you turn it into full circle.
I don't see any knobs.
No, not that. You can turn that off, otherwise everybody can hear you.
Oh, turn this off.
The switch says off.
What happens if I'm always on? Then I have no choice. Okay.
That'll be fun.
It's a gallon of brain and like gallon and a half of knowledge. You're gonna have to get rid of some of all of that extra knowledge. So I guess switches is something
That jar with the rocks and the water and say,
It was the extra golf ball. We tried to put it in the very back. That was, how on and off switches work.
that's a great analogy. I think I might use that in my intro.
Thanks. Yeah. Are you all right? It's probably more nerve-wracking for you, like if you're preparing me well enough, if you educated me well over the last 4 years, it's a big reflection on your abilities as an intern.
Now you're getting me nervous.
Front lights?
Yeah.
Do you want the real title slide now instead of the Zoom slide?
Yeah. All right. Thank you for coming to Dustin Groom's Dissertation Defense. I'm not going to spend too much time on the introduction here because I could spend hours and hours on talking about the things that he's done and the impact that he's had on our program, our lab, myself, and everything associated with this. And this is kind of a group that shows this. There's individuals who are part of and they're intertwined in here, part of the committee. I want to make sure that I have everybody from the committee here. 1, 2, good. I wanted to make sure. So everybody from the committee's here. He's got classmates, he has people from the program, he has people from other programs, he's got former students here. He's got family in the back. Thank you, family, for creating a great person. But it's not done by himself. I know that. And we decided to turn up the heat just for one last test on him and knocked out the air conditioning. Thank you, Dr. Larson, for helping us do that. The idea of this defense, the format is going to be, we're going to have approximately a 40-minute presentation. Then we'll have some questions from the audience. And then at approximately 9 o'clock, we will start our exam. Everybody will leave except for the individuals from the committee. We will ask and pepper with questions. And then we'll have a committee decision, so on and so forth. There's plenty of food back there, so please, thank you to
Louise, Eric, Dan.
everybody in the committee,
Megan, everyone.
this committee, as far as his fellow classmates for getting the food. And please eat up and do those things before we start our committee discussions, because we'll go back there and go. Dustin said something here that I wanted to kind of talk about. He said, "Are you nervous? Because this is a reflection of your mentoring and your work." And I can tell you, driving in, I was a little bit, I was just kind of like, does he have this ready? Does he have that ready? And then I just sat and just opened up the car door and go, he's been ready for months and probably for years for this moment. I'm not concerned at all, and I think this is a display of what he can do and what he's done and everything that he can show you that he's going to do in the future. So, Dustin, no pressure.
Excellent. Thank you. Is the mic working? I cannot tell. Excellent. Thank you, sir. So as Jimmy said, the title of my dissertation is The Neuroplastic and Neuromuscular Effects of Knee Anterior Cruciate Ligament Injury. So first I'll talk a little bit about what this injury is. It's a torsional or usually rotary force injury at the knee that ruptures the anterior cruciate ligament, which is a vital intra-articular stabilizing ligament. Females are at much greater risk for this injury. And it can happen also in activities of daily living, just stepping off a curb wrong. It's not just a sport injury only. It's just most commonly associated with active lifestyle. And if we look at the international epidemiology, you may think, well, 100 per 100,000 people, that's not very much. But if we focus in on high school or collegiate level or highly active individuals, the injury rate goes up exponentially. And what's most concerning about this injury is that up to 70% of them are non-contact, where the person just loses neuromuscular control during an activity, such as change of direction, or stepping off a curb, or landing, and the knee collapses and the ligament ruptures. So it's thought that all of these injuries should be technically preventable since they're not due to an external force from the body. ACL rupture in the United States costs up to $6.5 billion a year. There are over 300,000 reconstructions every year. This is due to the knee being inherently unstable if there is no ligament. One of the more pressing concerns after this injury is that they go on to rapid osteoarthritis. So you essentially accelerate the aging of your knee up to 2 decades after you experience this injury. And then most concerning for me, and one of the inspirations for this work, is that up to 30% of individuals, after we return them to sport, will go on to tear either the ACL graft or the other side. So essentially what we're doing today as an athletic trainer, treating athletes, 1 in 3 of my athletes, I will fail them. And that is just too painful to deal with. It's very, very depressing almost. And then recently, or not recently, in 2001, there was a Philadelphia panel review looking at what do we do today for knee pathology? How do we treat them from exercise to modalities? They essentially show that what we're doing is largely inefficient for patient outcomes. And just to frame from a more global scale musculoskeletal pathology generally, in 2012, the NIH funded the Bone and Joint Decade. And musculoskeletal injuries are the most common complaint affecting those in the United States. Up to 50% of Americans will present with a musculoskeletal injury lasting more than 3 months of dysfunction. This is greater than cancer, greater than motion disorder, greater than anything else. And half of those musculoskeletal injuries are related to the knee. So that means if half the people in this room will have a musculoskeletal injury affecting them for 3 months, affecting your life, half of you will be related to your knee joint in your lifetime. So 1 in 4 here will have a knee problem. So this leads me to think, well, what are we missing in our rehabilitation? What can we do better? The journey for that question for me didn't really start with that literature. I kind of found that on the back end. It started for me when I was just a student. First I was at Northern Kentucky University, and I thought I would learn everything, and I'd never have an athlete re-injure, and I would do perfect rehabilitation. And then I'd go on to graduate school, and you start to learn that maybe we can't do a lot of things, a lot more that we don't know. And then treating patients at the College of Mount St. Joseph in Cincinnati for a few years, I started to be a little disappointed in everything we could do, and I felt like we were missing something in our rehabilitation clinically. And then while I was there, I thought, well, if I'm having a little struggle with rehabilitation, I'll try doing injury prevention. So injury prevention for ACL injury is commonly designed to prevent this sort of movement, this medial collapse of the knee. And so we train people to move and land with this sort of movement pattern, and you would say this is correct and this is incorrect. So we try to get people to move, land with as much of a neutral knee alignment as possible. And this is one of the classic pictures from Meyer's work showing that this medial collapse and leading to ACL injury, so this lack of neuromuscular control. This is what it may look like in the lab. This is a typical assessment that we use to measure neuromuscular control and measure injury risk. And some people associate this movement pattern with just poor athleticism or poor strength. This is Robert Griffin III, an NFL quarterback. He's arguably one of the most athletic humans on the planet, and he has a similar motor control strategy as the young female that's predisposed to the ACL injury, and he's gone on to have, I think he's on his third ACL injury. And then you look into the rehabilitation or the prevention programs, and we see while they are successful, there are still non-contact injuries occurring in the treatment groups. So that means even with our best neuromuscular control programs, people still get this injury from a non-contact mechanism. And this idea that we're missing something was really driven home for me. I did an internship with the Cincinnati Bengals, and Carson Palmer tears his ACL. And as you see, the evil Pittsburgh Steeler, Kimo von Oelhoffen. So we were going to win the Super Bowl this year, and they stole it from us. It was a very traumatic day. It was terrible. I know it brings tears to my father every day still. So I'm a part of this rehabilitation team. He tears his ACL from a contact mechanism. So he might have not had any of these intrinsic factors that lead to injury. And we had everything on the planet you could think of. We had 6 treatments a day. We had everything. And he still went on to have another injury while he's at the Arizona Cardinals. And he never said he felt the same. He felt like he was always missing something. So he had the best surgery in the world. He had the best rehabilitation in the world. And he still never felt like he was as good as he was. So it's like, if we're missing something at that level, I can only imagine what we're not doing at our patient level. So that brought me to Ohio State, where I thought, well, I'm going to figure this out. I want to find the answer. And at first I thought the answer was in biomechanics. So this is in our movement analysis performance lab. I thought we would find the answer in how people move is how they're getting hurt. Well, we need to measure how people move. And using this technology, we're able to measure any movement to an extremely high degree of accuracy. So if we use this literature and we look at how people are moving biomechanically after the injury, what do we know? So we know up to 2 years out, people's walking kinematics still have not normalized. They still have more tibial external rotation. So even with simple walking, after reconstruction rehabilitation, these individuals aren't walking normally. Then we look at muscle activation strategies. After a year, they still haven't normalized. They're still changing how their muscles are activating just to walk. And this is one of the most telling papers from Lynn Snyder, Mackler's lab in Delaware, that at 2 years, so we always think it's a strength problem. We need to recover strength. That's the problem. We can recover quadriceps strength, and you're even a little bit stronger on the involved knee, but that doesn't mean they're going to use it during gait. So they're not going into as much knee flexion or extension. They have less excursion of their knee, even though they're just as strong. So something is going wrong in the motor control system that we're not addressing. And then lastly, Dr. Meyer demonstrated that there is actually no association between time from surgery and how people move and their functional deficits. So we used to approach rehabilitation from a time point. If you just give enough time, people will get better. We found that's absolutely not true. They don't get better. So what could we be missing in our current approach to musculoskeletal medicine and orthopedic care? Up until a few years ago, we focused on this final output. If we think of neuromuscular control as this spectrum of control, we have our final output of the mechanics of motion here. This would be the last step on the motor control paradigm. Everything else, this is like the final output of your system. But however, everything that goes into it, we have largely left unmeasured in orthopedics. So there's a great deal of neuromuscular sensory motor processing that goes into generating these final movement mechanics that we see that we've been measuring for the last 20 years. And what's interesting is recently out of Sweden and Fridden's lab, they've done a series of studies, but they've showed you can even normalize these final mechanics in the laboratory, but you'll have all these underlying deficits from somatic sensory potentials, proprioception, force control, that may have implications when people go back to their activity when they go back to the real world. So what does ACL injury do? Why do I think it may cause affect the neuromuscular control paradigm more than just the structural component that we tend to associate with ACL injury. The conceptual model is that after you have an ACL rupture, we get the mechanical instability and we get pain and inflammation. What's interesting is that the ACL is highly innervated with mechanoreceptors. So this just means there are sensory organs that tell your nervous system what your knee is doing. There was a great study by Park that looked at rats, and they used antiviral targets into the ACL, and they tracked. So if I inject the ACL and I can see the tracers, where does it go? Where is the ACL connected in the nervous system? They found all the way up into the sensory cortex in your brain that there's a direct connection between the sensory cortex and the ACL. So there's clearly a neural component to this, what we used to think of as primarily a structural injury. So this all combines to disrupt the afferent signals coming from the knee. And we see this displayed with inhibited spinal reflexes, so they're less able to accommodate perturbations at the knee, and also a overall inhibited alpha motor neuron pulse. That just means they're not able to contract the muscles around the knee due to the nervous system shutting them down. This leads to what some may consider a low-level joint deafferentation effect, which forces the motor control system in the CNS to reorganize or repurpose how it's generating motor control. There's only a few studies that have gone this far, but we know that with EEG, if I stimulate the ACL directly in surgery, or I stimulate the tibial nerve that innervates the ACL, and those that have even had reconstruction, their sensory cortex will look like this, so largely blank. So these two potentials that are associated with the area of the knee innervated by the ACL, versus if you have your ACL and I stimulate the tibial nerve, or I stimulate directly mechanically in surgery, you can clearly see that the sensory cortex lights up. So there's a response from the brain. But even if it's reconstructed, it is not there. It is absent. And then along with that, there's a few studies in transcranial magnetic stimulation that show the brain requires more magnetic stimulation or more drive in order to create a muscle contraction. So they have depressed cortical excitability. So it's harder for the brain just to activate their quadriceps. And we think this leads to an adaptation in motor control, but however, there's very few studies that have examined these patients with a neural measure and a motor control measure. They're usually separate. But looking into the literature, trying to take it as a whole, we developed this hypothesis that maybe the brain will reweight or utilize visual feedback in the place of this disrupted sensory feedback in order to maintain motor control. And we think that for a few reasons if we go down the paradigm. First, we get this sensory plasticity from the disrupted ACL. We know that proprioception is inhibited, so this is the ability for them to reproduce a joint position in space. So we take them to a joint position, we say remember that, and they come back down, they try to reproduce it. That is worse after they've had the ACL injury, indicating they may have worse sensory ability. And they have even worse force control ability. So I tell them to match a certain level of force, and they struggle to do that. And in a very interesting study out of Germany, they used EEG and they had them do the same task. So I can look at how is the brain activating to do this task. They found if you're a control participant, it's relatively easy compared to the ACL individual to do the same task and actually to do it worse. The ACL person essentially had to use more of their frontal cortex and the parietal cortex, so more sensory and concentration areas of the brain to do the same task and not even do it as well. So this leads to this disrupted sensory function to the brain has to use something else to help program motion. So these are the couple studies that looked at if I take away vision and I do a double leg to a single leg transition or I do a balance task, the ACL individuals have much worse postural control. But if I allow vision to be open, so I allow their eyes to be open, I allow them to have vision, their postural control largely normalizes. So they're basically able to compensate if you allow them to see, and they fail to compensate if you take away vision. And then in 2009, there was one fMRI study that found increased activation of the posterior inferior temporal gyrus during just simple knee movement. So what this area does, it does visual processing, some spatial awareness. So they're using an area of the brain that shouldn't really turn on. So in their controls, this area didn't turn on at all. But in the people who have torn their ACL, they activate an area in their temporal lobe to help with visual processing and visual feedback. So combined, we think after this injury, we have this change in the nervous system, we have this change in motor control that forces the ACL to reconstruct individuals to re-rate and use vision. But then we return them to activity, return them to play, and we see this sort of mechanism often. there are several studies looking at just coaches' videotape of people who've torn their ACL. And in 90% of them, there's a ball within 1 meter, there's another player within a meter, their attention is focused elsewhere. It's usually at a tenser time in the game. So cognitively, they're distracted, and they're having to engage their environment. And then in the laboratory, since it's very difficult to perturbate vision beyond doing just simple eyes closed balance, we know that if I put a defender in your way, or I make you choose a target, or I make you interact with your environment, if you've had an ACL injury, your mechanics get worse. You tend to not do as well. You can't compensate and dual task essentially as well. So this brings me to the current work. What I want to talk about today is how can we measure this neuroplasticity if it exists after injury, and what are the behavioral manifestations for this injury? Is visual motor control a driver of this neuroplasticity after injury? So our first aim is how do we measure the brain? The current best tool for measuring in humans is to use neuroimaging or fMRI. So what you're seeing here in red is someone who's torn their ACL and they're just moving their knee. And in blue is someone who is healthy, it's their match control, and they are moving their knee. So just qualitatively, you can see a different activation between the red and the blue. So our first aim is we want to identify this activation pattern for people who have had ACL reconstruction versus the matched controls. And our hypothesis was that they will activate more sensory, motor, visual motor areas. And then our analysis is a paired analysis. Our design, we had 15 ACL reconstructions, 6 months to 5 years out. So we have this cross-sectional design, this little bit heterogeneous population, but allows us to get an idea of how the neuroplasticity may change over time. With no neurologic disorders, no return to physical activity, they have to have no metal. This turns out to be one of the hardest things to do. With this, everyone has a permanent retainer now. Everyone wore braces when they were kids, and I need to pay an orthodontist to rip them out. You can't scan their brains if they have permanent retainer. And we had 15 age-matched controls. This was a big difference between the first Caprelli study in 2009, is that they used the worst functioning group of ACL people, and they matched them to healthy, active people. So we took a group that was very high functioning with a high Tegner score and a high Mark score. So these are levels of activity. And we matched every single person on their sport, their education level, their current activity level, their activity level history and height and mass and gender and age. So we went through a lot of great pains to make sure we got as close a match as we possibly could to everyone who's torn their ACL. And then we powered this from a previous study and also our pilot work to detect our primary regions of interest differences. So to measure the brain, our movement paradigm was rather simple. It's just a block design. So they'll spend 30 seconds resting, then 30 seconds moving, and then resting, and then moving. And that allows us to get a contrast or a picture for how they move versus how they're resting. So this is what the paradigm looks like. So if this is followed and preceded by 30 seconds of rest. And if I contrast the rest condition with the movement condition, I'm essentially able to get what are the brain areas that activate when you're doing that condition if I take out the rest condition. So for the ACL reconstructed individuals, one of the areas activated the most was their contralateral sensory motor cortex. So this makes sense because the contralateral brain controls the other opposite side, or the opposite side of the brain controls the opposite side of the leg. Anyway, so these are all left reconstructed ACLs. So we saw great activation on the right sensory motor cortex. So this makes sense with the literature showing depressed cortical excitability. So they need more drive to create the same movement or to create the same muscle contraction. And in secondary analysis, a lot of this is driven by increased supplementary motor area activation. So it seems that this increased motor cortex activation is driven by a need to engage in more motor planning. And then we also saw a decrease in the ipsilateral sensory motor cortex. So this area, at first you may think, well, this isn't really involved in moving the same side. But in the legs are much less lateralized than the upper extremity. So you'll see a lot more bilateral activation to move your legs. And essentially the other side will actually activate a great deal to inhibit bilateral motion. So our legs are designed to do gait, so they're designed to move one right after the other. So the ipsilateral motor cortex will tend to activate to suppress moving the other side. However, if you had an ACL reconstruction, you've gone through extensive therapy, you've gotten really good at moving just that one side. because for 6 months you focus just on moving the ACL side. So it's possible that through the rehabilitation, these individuals are more neurally efficient at suppressing moving their non-involved side. And then 2 other areas that activated more in the ACL cohort, we saw increased lingual gyrus activation. So this is one of the last areas on the visual processing stream. It's in the occipital cortex. What's interesting, this area will activate a lot if I have you navigate a 3D world. It'll activate a lot if you're doing spatial awareness. If you're viewing motion, so it's a high area for watching biological motion, and also keeping things in visual memory. So it's, even though this task is very, very simple, the ACL reconstructed people are using a more of a visual processing area to move. And lastly, they activated the secondary somatosensory cortex to a greater degree. This area tends to activate bilaterally. It's not as unilateral or lateralized to the primary sensory cortex. And it deals with alternative sensory feedback. So not just proprioception or afferent signals, but it'll deal with pain or thermal or heat processing. These individuals in the study, they were pain-free at the time of scanning, though, and we'd have them do a survey if they felt any pain during the movement, and none of them did. So this may mean the sensory areas have changed their activation profile from the chronic pain or disuse earlier in the therapy or earlier from the injury. So what does this activation really mean? And this is a problem right now in the neuroimaging literature when analyzing group data. So I've given a hypothesis or a conjecture for why each area activated more or less, but trying to figure out what it means is difficult. So is more activation really good or bad? Do we want to encourage this neuroplastic effect? Is this from rehabilitation? Is this from injury? We don't really know. So what we really need is behavioral data to interpret what the neuroimaging differences mean. So our behavioral task is the drop landing that you saw earlier. And we chose this task because it's sort of become a classic measure or an assay of neuromuscular control in sports biomechanics. It's highly related to joint coordination, stiffness, spinal reflexes, isokinetic strength. But more importantly for this study, being an injured population, your movement profile during this task is related to your risk of sustaining a primary and secondary ACL injury. So people tend to move this way with less knee flexion and their knee collapses towards midline. A key difference for this is that we added stroboscopic visual disruption. So if our hypothesis is that the visual motor system is altered after injury, then we needed to do a task that it knocked down or disrupted visual motor processing, try to figure out how does that contribute to neuromuscular control. A problem with the literature up until this point is that to do a visual motor knockdown, we had to do eyes closed conditions. So you could only do standing or very simple movements. These glasses essentially allow you to do any task and just knock down or disrupt visual feedback. And then we can look at the contributions that visual feedback may be playing in the movement. And so for us, that allowed us to do the drop landing and then reach up and hit a target in the air that we couldn't do if we just did an eyes closed condition. So our aim 2 is to assess visual motor control after ACL injury. Our hypothesis is that on our key variables for neuromuscular control was knee flexion, so how much do they bend their knees in the landing, and then how much do their knees stay in a neutral position, or how much add or abduction they go into. To assess this, first we did a repeated measures de novo. So we have 4 visual conditions. We have the full vision, so they could see. And then we use a low stroboscopic condition, which means the strobes fluctuated at a low rate. So they could see, they couldn't see. So the rate of that disruption was low. Then we did a high condition, which was supposed to be more challenging. And then we totally took away vision and removed the target just to see what was the total contribution of vision, or how do you change if I totally remove vision. From that initial analysis, we saw there was a lot of variability in how people responded. So we looked at what is the peak effect of this stroboscopic condition on the ACL versus control cohort, and then just to see if this disruption does anything at all. We did a 1-sample t-test compared to the error of the measure. So we know there's a certain amount of error in all of our measures, so we wanted to see, is this actually changing movement beyond just repeated testing? So our first measure was sagittal plane kinematics, or how much they bend their knees. So there was no effect for gender, side, or injury, so the whole group responded in a similar manner. Everyone tends to increase the amount they bend their knees, the more I disrupt their vision, which sort of makes sense. If you delay visual feedback, they may have to bend their knees more in response to the landing. But then we look at how did the people respond on an individual level. So this is the really more interesting component, because I'm interested in how did the ACL people respond versus their matched control. And we see the ACL individuals, they tended to increase flexion to a greater degree than the control participants. So they tended to change their landing strategy to a greater degree than their matched participant. And then we look at, well, did the stroboscopic effect induce a change in kinematics greater than error? So typical error for knee flexion is only about 3 degrees. And we found that it did. So the group as a whole experienced a change in their flexion kinematics. And the second variable, looking at knee frontal plane, so how much their knee collapsed in or out, we saw that in the stroboscopic low, they landed in a more knee valgus or more abducted position. And then as we perturbated vision more, they approached a more neutral position, or they started to go up a little bit. And once again, we found no effect for injury side, gender. But then we look at the paired analysis, and we see the ACL individuals, once again, they tend to increase abduction. So this would be a worse landing, or more injury risk landing with the glasses on. But for the paired effect, there was no difference because we had a few ACL people increase or go into a more safer position or a neutral position. Then looking at the group as a whole, does the stroboscopic glasses induce any sort of effect? We found it was greater than error. So both knee flexion and frontal plane kinematics change greater than error if I have people wear these glasses. So you may think, and I originally thought this when I looked at the data, well, you have about a 4-degree change in how much they bend their knees, you have about a 2-degree change in frontal plane kinematics. What does that really mean? So how does that compare to what else I can do in the literature? So if I give someone a feedback, so I tell you how to land immediately, and then I have you land again, this is what we see from just a quick self-directed feedback intervention. So our change in kinematics is actually greater than the change from giving someone one session of quick feedback. Now, that one of the differences is if you give quick feedback, they tend to land in a more neutral or a better knee position, whereas the visual feedback disruption for us, they land in a more valgus or worse knee position. And then if I do an in-season training program for soccer, so if I train you for 6 weeks and I give you neuromuscular training and jump training, we see our effects are greater than doing a 6-week-long training program. And then lastly, Dr. Yam's work, he did a in-flight perturbation. So during the landing phase, if I actually give you a force, that's 15% of your body weight, our change in knee flexion from just messing with your vision is actually greater, and they had a little bit more change in frontal knee alignment. So the fact that I'm just perturbating your visual processing with the stroboscopic condition is in line with all of these other interventions. That tells me that maybe this is actually doing something that's worthwhile, that's worth investigating. So my next question was, well, why do some of these people respond? So looking at the change scores, we see a group of people that will respond to the visual disruption and a group of people that kind of sort of don't in the ACL. And then the same way for abduction. So what is going on? Why? So my hypothesis from the beginning is that, well, the brain is changing and the brain is undergoing some sort of visual motor adaptation. So aim 3 was to examine this. So identify the relationship between brain activation and these key kinematic variables during landing. And our hypothesis was that these motor-related brain regions will be related to how people land, to their neuromuscular control profile. And we used just simple correlation, and we looked at percent signal change of our regions of interest. This just means how much they activated during the movement condition contrasted with the rest. Then we looked at the stroboscopic kinematic change score. So basically the change score from the full vision condition to the peak visual disruption condition. So once again, our 2 key variables are how much they bend their knees during the landing and how much their knees collapse in or out or stay neutral. Our 2 brain regions of interest that were most related to motor control were the motor cortex and the lingual gyrus. So we looked at the area that's responsible for all the motor drive going down to the knee, and then the visual processing area that we hypothesized is going to be related to their spatial awareness and visual feedback. So the first one, so we found that lingual gyrus activation was related to knee flexion. So the amount of the visual processing area in the brain, the more it activated, the more they bent their knees during landing. So the more the stroboscopic condition induced them to bend their knees more. What's kind of interesting, people that didn't really use the area at all, or used it very little, they would land stiffer. So they actually adapted what would be a negative adaptation to their neuromuscular control system. And we found no change in frontal plane alignment for this variable. And then we look at motor cortex activation. This was related only in the ACL group to how much their knees collapse in or out. So the more their motor cortex activated to move their knee, the more likely they landed in a more neutral position or they went into more adduction. But if it activated less, the ACL individuals tended to land in a more valgus position or a poorer position. So this means maybe we want more motor cortex activation for knee movement to adopt a better motor control strategy. And we found no relationship in the healthy group for this variable. We think that's maybe because the movement's relatively simple, so it may not have taxed the motor cortex as much as the ACL group. So our findings were that if you increase motor cortex activation and lingual gyrus activation, we saw increased knee flexion, good, and we saw increased knee adduction or away from a valgus or a bad injury risk movement. So what does this mean? So I went into this study and I went into this thinking that if the brain changes after injury, this is probably bad. I want your movement strategy to look like the control, right? That's what I would think. So if you made it your whole athletic career and you never got hurt, this is how your brain activates to move your knee. I would think, well, if you did get hurt, I'd want your brain to activate like that person. If it changed at all, it's probably bad. But what this study means that maybe that's actually good. The people who had the biggest activation and the largest change, they adapted a better, more optimal neuromuscular control landing strategy under the visual disruption. So look into the literature. There's a few studies by Courtney out of Pennsylvania, out of Pitt, that looked at somatosensory evoked potentials in ACL copers. So what this means is if I stimulate the knee, I can use EEG, I can read how much activity do I get in the brain if I just stimulate your ACL. What she found was that if you do really, really well after ACL injury, and you don't even need surgery, you're so good, then it's totally gone. There is no somatosensory evoked potential in your brain. There's a total loss of connection from the ACL to the CNS. And if you do really, really poorly, then you might get some. You always have some connection. It's usually not as good as controls, but there's some feedback still getting to the brain. So this is counterintuitive because you would think, well, less connection, bad. But what happens is the people that recognize, if the brain recognizes the instability, they adapt their motor control strategies. They had increased hamstring activation. They bend their knees more. So it's almost like the brain realizes it's unstable and activates differently to compensate for that. And maybe we need to encourage that. And then recently, Petra Simone, the last couple of years, has done a lot of work with transcranial magnetic stimulation. So essentially, I stimulate the motor cortex and I see what happens at the muscle I'm stimulating. And he's shown that if I give people visual feedback, I can enhance cortical excitability. And it's to a greater degree in the ACL individuals. And then also, the people who have the most increase in cortical excitability along the rehabilitation timeline, so he did a longitudinal study, if I can increase that excitability, then I tend to have more strength, I tend to have less quad activation failure, I tend to do better. So the people who have the biggest cortical change do better than the people who do not. And then looking at motor learning, is the rehabilitation causing this? So we know that and if we do a lot of musicians, pianists, that if they do a lot of training in their fingers, they are better able, they activate more when they're learning a new task. So maybe the rehabilitation is causing some of this change. Maybe we've increased size of the knee area in the motor cortex because we've done so much unilateral rehabilitation. So some of the limitations with this work is that this is all correlational. It's not longitudinal. It being cross-sectional, I cannot know if these changes predispose people to the ACL injury or if the ACL injury and rehab caused some of these changes. Our ACL group was heterogeneous, so even though they were matched very, very specifically to their control person, as a group, we had a variable time from surgery, we had variable gender and sport participation. This is retrospective, like I said, so we can't really know if this is a predisposing factor or if the rehab or the injury induced it. The task differences, so a drop jump is clearly very, very different than knee flexion extension laying supine. That's one of the reasons why we looked at the change score. So we isolated just the contribution of visual feedback to the drop landing. That's why we theorize that's why that specifically is related to brain activation. The last one, our visual perturbation was block design. So we scaled the visual knockdown from low to high to blind. So it wasn't a randomized order. We did that for a few reasons. We wanted to look at how clinicians would use this. So we had a scaling effect. But that also may allow visual memory to play more of a role in the kinematic changes because they are able to know what's coming next. And they're able to have done the full vision first. So that may have played a role. In the future, I think we can look at more how neurophysiologic correlates with biomechanics and how movement, and we can start to join neuroscience with movement science and understanding human lower extremity motor control. This is a recent invention out of MIT. This is their approach. So if we're going to try to understand lower extremity motor control, we can design something like this and do fMRI. I think it's a bit of an overkill. We may be better off if we do more of a multimodality approach and we use all the information that cortical excitability and TMS can tell us, since we can draw a little more causation with TMS because we're inducing the stimulus, and do a little bit more of an advanced fMRI paradigm with more of a closed chain instead of an open chain. Also, we're trying to translate this, something Dr. Onati is always yelling at me about. We need to figure out how are you going to translate all of this fancy stuff. So one of the other tasks we did that I didn't talk about too much is we did the single leg jump landing. So they do 3 jumps and they got to stick the third one. So this is someone who's a control participant with their eyes open. This is a control participant with their vision occluded. So you can see they're able to compensate. They do pretty well on both. They do pretty much the same. But if we look at an ACL individual, you'll see you get a big change when they go to eyes closed, so the visual condition on your right. So this may allow a quick clinical test to identify these people who have this visual motor over-reliance for movement. And the last part, rehabilitation. As clinicians, we can maybe induce or encourage these adaptations that can affect neuromuscular control. If we adopt this integration of visual training with our classic approaches, we can maybe cause a more adaptive approach instead of suppressing it. So we may want to train the visual motor system along with the neuromuscular control system in our rehabilitation. I think this is just a very exciting time for kinesiology, for physical therapy and athletic training. So thank you very much. I'd like to acknowledge my wonderful committee. This is the most recent pictures I could find of them. They've aged very well. Very, very handsome people. This is I'd like to thank the wonderful CCBBI, Center for Cognitive Brain Imaging staff for all of their help, all of my lab mates and great people. Most of you are in this room. Thank you very much for the last 4 years. It's been spectacular. I'd like to thank the NIH and the Department of Defense for helping fund me as a student and allowing me to do all this work, and Dr. Onati for getting those grants. Very important. And then the NATA, National Athletic Training Association, and the National Strength and Conditioning Association, and the OSU College of Medicine for funding this work. I'd like to thank my wonderful friends. They've been great to have the last 4 years. It's been spectacular. We had a lot more fun in pictures than I realized. I didn't really think. This is all of them, by the way. This is all the fun. We've only had 6 funs. And then, of course, my wonderful family. Thank you for coming today. It's my nieces, my sister, my mother, father. I don't know what's going on there. It's my grandmother and grandpa. And then if there are any questions, and thank you very much.
Good job.
Dr. Buford.
I have a question.
Excellent.
First of all, great job.
Thank you.
That was really nice. As you were presenting, thought crossed my mind, and maybe this was your point. You talked about how people with ACL reconstructive injury do poorly when faced with a defender, for example, basketball player trying to make a cut.
Mm-hmm.
And you seem to have demonstrated here that with their impaired proprioception in their knee, they shift to a more visual control strategy to adapt for that. And the question is that good or is that bad? Should we train it or should we extinguish it? Or should we transition them out of it? Do you see a link between this, what you call
So when I went into this, I thought we want to extinguish that. That's what I immediately thought, is that this is bad. This is not good. So the visual disruption was, I originally thought they would create a much worse. They would just do terrible if I did it. And the fact that the people that had the greatest brain activation kind of went the other way, I thought was very interesting. But then in the visual disruption is designed to be that, to force you to use other systems. So I'm not really sure what the mechanism will be. So I would need to do like a longitudinal rehabilitation study to figure that out. Do I want to just improve their visual motor function? Like if I can improve their reaction time a little bit, and maybe they can deal with the defender and deal with the task and dual task a little better? Because there's not been a very good link that shows if I do a lot of eyes closed training, can I even improve the proprioception to a significant degree? So can I even restore the sensory system at all? I might not be able to. So then I would just have to improve the visual motor system and just hope for the best, right? But I went in hoping, we'll extinguish the visual motor thing, and I'll make you use sensory, and I'll turn you into a control. And I don't know if we can do that.
Right. And it'd be interesting to see if the people who were more reliant on visual motor strategy were worse at the dual task.
So we did do several dual task
Cortical
discussions.
processing just to move their knee, that they're that much more challenged when they're faced with a secondary situation.
Yeah, that's very good. And we did a couple dual task tasks to look at next. Yes, Dr. Bass.
It seems to me that the issue here is feed forward versus feed back. And I'm wondering if you had any measures of feed forward processing, and perhaps I'll throw this out here, are you targeting the right joint when you're doing your rehab, or even when you're doing your analysis?
So to look at feed forward, you mean like EMG prior to landing, something like that? So we collected that. So that's something that was one of our questions going in as well. There's an interesting study just recently in Journal of Physiology where they did a drop landing task, like similar to this, where they let the floor be removed so they could punch through the floor, right? So they were trying to get at how long until you hit the ground could you have it before people adapt their motor control strategy. So they found it was faster, so like 50 milliseconds was their cutoff. And so they basically showed that people could adapt at a faster pace than it should take for the neuron in your foot to go to your brain and back to adapt it. So they thought, well, you must have this like sensory prediction framework or this feed forward framework that you're expecting a certain condition. And then when it doesn't happen, the connection may be able to happen at the spinal cord that they adapt, because you suddenly had, instead of having to go to the brain and back, it just goes up one and you know something's wrong. So the visual feedback, they may be relying more on that because they're using visual processing, which we would consider to be a feed-forward mechanism more than likely, I would think. So if we did do a reaction task. It's not part of this presentation. So we wanted to try to get at that a little bit. So how do they do it if they know what's going to happen and they have the visual memory versus if they have to do a reaction? So we could get reactory task versus a preparatory task. That's a great question. Especially it'll help us just know how does this visual processing play into motor control for these complex tasks a little more as well.
Did you instrument the trunk?
Yeah. We did not do trunk EMG. I have hip. I'll add it to the next study. Write that down.
That's where the feed forward is going to be, is in the trunk.
Some of the videos that you were showing, especially the last one with the typical subject and the ACL subject,
Yeah.
where the ACL subject is having,
Sure.
reminds me a lot of developmental coordination style. And I'm wondering if you are describing a central coordination problem that might have implications in some other populations. And with that thought, has there been any work that compares people who've had ACL injuries with people who are not coordinated? And I actually think that might get a little bit at Michelle's question.
So a couple of our control subjects were definitely not coordinated. So that's a good question. So if we make the control group, if we find a little more uncoordinated. So if I was a control, you're right, I would make an excellent control for your question. I'm not aware of anyone who's done that like a priori to look for that. If I take ACLR people, a lot of times when you match them to activity level, you tend to get pretty athletic people. So it's something we could look at. I know the couple people. So if in the data, some like the controls, the relationship was there for like the visual motor area, the lingual gyrus. Some of the controls activated that area a lot, and they moved kind of like the ACL people. And a couple of the uncoordinated people I know, because Mike McNally asked me this question. He's like, "What's going on with?" There was 2 or 3 people that shouldn't have been in the study. Maybe they lied on the survey or something, or they played on the sport and they didn't get a lot of minutes or something. I don't know what happened. But and I looked at their data, and they tended that like last picture. They tended to move that way. So maybe they're just waiting to get an ACL injury, like those people. That's a good question. Dr. Borstad.
Dusty, that was really awesome.
Cool.
Excellent. I'd like you to address for us a
Sure.
little bit more about your comment on pretty much all of your areas look like there was adaptive or positive neuroplasticity versus maladaptive neuroplasticity. And specifically, did you look at your ipsilateral deactivated area in relationship to behavioral tasks? And if I missed that, I'm
Sure.
sorry.
No, you're good. So, you're right. Most of the areas activated to a greater degree. Very few activated to a less degree. One of the things with this study, with this analysis, I set the threshold and the p-value were a little bit. The p-value and the threshold were a little bit. P-value was lower, threshold was higher than in Caprelli's study. And the reason for that, the Caprelli study was the first one to do neuroimaging, is that they had about 8 areas activate less, but they didn't do a correction. So they just lowered the p-value a lot. So they had some methodological problems with their study that I didn't want to make. So if I was thought I want to say something's activated or deactivated, I want to be very, very sure. And I didn't like the design of their study. So there may be areas that are deactivating to a lower degree that I didn't capture with this analysis. But we elected not to do that so we'd have a stronger result. And then to get at the second part, did I look at that deactivation on the contralateral side? So our analysis, we looked at just the involved knee. So I didn't look at both knees. And I didn't run the correlation with the contralateral side. One reason is that I didn't want to just keep doing correlations because in fMRI data, as you know, there's a lot of concern that you get just spurious correlations with behavioral data. So I wanted to cut my hypothesis as clean as I could. But that's definitely an interesting area. So is the deactivation part of their adaptive strategy?
Or maladaptive.
Yeah. Yeah. Or and then I go back to, is more activation necessarily pro-adaptive or not, Mal? So like in stroke a lot, you want more because you're just not getting anything. But in this kind of condition, I wasn't really sure if more or less was better. So I don't know if the ipsilateral sensory motor cortex, if less activation is going to be good or not. That's a good question. Dr. Briggs.
Thanks, Dusty. Very nice. A little different question. So the glasses that you use.
Sure.
After using them in your study, I guess what would be your feedback in terms of their clinical utility, either in the rehabilitation process or the performance, sports performance aspect of things, and/or you would recommend one way or the other?
So I think they do have utility, especially towards the end stage functional rehabilitation. So if you can take those glasses, and then I can basically, it adds a layer of visual processing or disruptive visual feedback that's hard to replicate. So in the clinic, so you can use them, you don't need like another defender or another person, and you can just basically add another layer of cognitive difficulty to all of your tasks immediately. And you can do it in the feedback-rich environment of your clinic. So I think that's an excellent tool. But from a early stage, I think it may be that we don't want to induce this cortical connection right away. Because as we look at some of the other data that I've been looking at further, that if the task gets more complex than the jump landing task, we don't necessarily see the same adaptation. So we may not want to encourage this visual motor knee connection right away. So if you think about therapy, the first day of therapy, you stare at your quad, and they tell you to make a quad. You do that for about 3 months, and you just hammer that. So we're just maybe inducing this mind-knee connection. So I would like to see clinically not only the glasses used later as a part of return to play criteria or part of functional rehabilitation, but also very early on incorporating a dual task or incorporating a visual motor task along with your knee extension flexion, your quadriceps strengthening exercises. Other Dr. Porstad.
I thought it was interesting that there was sort of this inverse relationship during the landing task between flexion and abduction. So in the ACL group only, though, not
Right.
the controls, suggesting that there's almost some interaction effect between these two planar motions. Is that typical of someone who will have an ACL injury? Is it predictive, or is it a compensation pattern, or is this a well-known thing? I thought.
Yes, so like in Hewitt's and Paterno's study, the second injury risk, so the primary predictor was frontal plane, like valgus collapse, but they both had less knee flexion too. So if you tend to land stiffer and you're not able to bend your knees as much during the landing, those people also tended to have more knee valgus collapse too, or knee frontal plane collapse. So I would say, yeah, they definitely are related.
So
If that's your
that was post rehab, and
right.
so that was a pattern that persisted.
And only some people, so some people activated more and landed better, but also 5 or 6 people didn't activate very much more, and they landed worse. The visual, so if you don't activate the motor cortex more or activate the lingual drivers more, you tended to do worse when I disrupted your vision. You didn't have a positive adaptation.
Yeah.
Right? I know.
Yeah.
I made the same face. Dr. Palmer.
Dustin, nice job. I've got a couple questions that I think related to some of the current conversation is the criteria for your match control in the first question, just to kind of,
Sure.
I'm trying to figure out if you screen for any vestibular issues prior to doing these tasks. And did that tie into your match control? And then the other part of the question, which doesn't really relate, but it's similar to the question we heard before, is right now, I'm going to leave this presentation, be so excited about what you just told me, that I want to put it into practice. So what do you tell the clinicians now in the room a little bit more in sync of how we use this information? Like what's maybe your main clinical impact right now?
Sure. So first one was the match control, right? So we do screen for any vestibular, neurologic, even like seasickness. If you have trouble with claustrophobia, laying down, the surveys we do is very extensive, and we actually used an online survey tool, and we screened over 500 people to get these 30 people. So it's very extensive control. And we also do a clinical test of sensory integration and balance, so like the Foman Dome test. So basically we do a visual and a vestibular perturbations. Also, so we have that data that we can categorize people by that. So they may not have a diagnosed vestibular or visual dysfunction, but we may be able to see that in that postural control task and kind of get more deeper into that. The second one about clinicians, so what would you do? So immediately I would recognize that everything I'm doing clinically is having an impact on the nervous system, right? So usually in athletic training, we don't really think much about that. I know it's a little different in physical therapy, but dealing with musculoskeletal medicine, we've sort of relied on this structural biomechanical model most of our history, which is not very long. So first I would think right from the beginning, right after surgery, like I was talking to Matt, I would try to engage them in a visual motor system, the visual motor as much as possible. So whether that incorporates like a dual task immediately, so once they can contract their quad, I start having them do math problems right away, have them do saccades on the wall or throw a ball. Maybe I tell them jokes or something, maybe I distract them. And then as they progress, I would keep that in mind. So I would love to just do like a randomized clinical trial and try all the neuroplastic focused interventions, everything from dual tasking, visual motor control. Can I Do I, like Dr. Buford talked about, can I restore the sensory system, or do I just have to make the visual motor system better? So at the end, as part of my functional return to play, one thing that might be missing, so we do strength, we do hop testing, we may do like a pro agility or something, but maybe I want to have them move or cut, and I want to qualitatively screen them when they have a defender there, or I make them have to focus on something else besides the landing, because right in front of you, when they can just think about it, they'll tend to do better. And then the last thing, the single leg hop, I think could be good as a quick screen to identify people that may engage visual motor control to it and have poor sensory motor control. So those are a few like pearls I would take. Thank you very much.
Wow, that was exciting. So thank you everybody for coming. Please eat as much food and take as much drink and cool off as possible. And again, thank you for everything.